Thank you, Mr. Chairman. I appreciate the opportunity for us to start focusing in on some of these items, and I appreciate in particular Dr. Holahan talking about the costs of doing nothing. And I think that is one of the things that is so critical that gets lost. If we float along for another year or 2 or 3 or 4, we are going to find more uninsured. We're going to find fewer people who are insured by their employers, and those that are going to be facing higher costs and less comprehensive coverage. I hope that we as a committee will be able, as we go forward, to look at getting more value out of the existing system. There is some in the draft that I like. There are things that I have in terms of end-of-life, transitional benefit. There are a whole series of things that I'm excited about, some of which are in the draft. We can do more. I don't think we've gone far enough in terms of dealing with radical disparities of Medicare reimbursement around the country. I'm particularly concerned that what is in the bill for Medicare Advantage will hurt efficient areas and will have virtually no effect on very high-cost states. But this is a process that I hope we can work on together. The notion of how we're going to pay for this is part of the cost containment. We have 3 or 4 years before this kicks in, so we'll have a chance to refine the getting more value out, and I don't think any of us feel that when the other areas where there will be some costs associated, and the polls show the American public is in favor of paying a little bit more, if they get security and 50 million people more or less get health insurance, they think that's a good deal. But it's not going to kick in this year or next year. We'll have a chance for the economy to regain its footing. I am a little concerned about the language here about somehow forcing people onto the public plan, because people will go into the exchange where the public plan is one of their choices. And that sort of gets lost in the discussion. And I want to pose my question because, Dr. Holahan, you referenced it in your testimony, but as I read it, it's a little esoteric, with all due respect, about where the Department of Justice thinks it's non-competitive and there might be antitrust. My reading of the data is that there are 25 states where one insurance company has 50% or more of the market. If you could perhaps discuss a little bit in practical terms about the lack of competition that most Americans face now with meaningful choices of health insurance. And my read of this is that the insurance companies themselves are going to be advantaged because we're going to streamline some of this process and squeeze out some of the goofy stuff that goes on. Right now, trying to deny people coverage. We're not going to have pre-existing conditions. That's going to be a level playing field that is going to make, I assume, a very big difference. And if you want to also comment for a second about the soundbite that you got trapped into saying about cost controls and then cut off if time permits to elaborate. But I would like you to talk for a moment about meaningful competition that we're going to be providing under the framework that's been offered.
Yeah, a few months back we had some executives from a big Blue Cross plan in Midwest visit us and to get advice on how they could control costs. And the first thing I asked was, how well do you pay relative to Medicare? And the answer was they paid 79% above Medicare rates to hospitals and 68% above Medicare to physicians. And I said, like, why are you here? They did this because they can. They have no competition, and they can pass on to the extent this means higher premiums. They're able to pass that on, and I think that is a role that this plan would have to, I think could help with, and help in those markets and help in others where there's more insurers, but one that's really dominant and still not able to deal with dominant hospital systems or single specialty groups that are essentially bargain as monopolists. And so,
thank you. I appreciate that. I would just close by noting it'd be interesting to take a test of the people on this committee who have health insurance. I assume most of us probably do, and find out how many of us made the decision based on what was the cheapest plan. It'd be interesting to find out if we could figure out what was the cheapest plan. I mean, I get my insurance through my wife's company because I think she has greater contact with their Department of Human Resources to try and decipher stuff that I can't. But I think the record is rather clear that there are lots of people, including in the federal system, and I'll bet people on this committee, who make lots of choices that aren't the cheapest, and it appears on that chart. And so I think the fear somehow that all competition would stampede to a public plan if it appeared a little more affordable is at least near-fetched. Thank you.